Hi everyone, my name is Ken Eto, and I'm your Farm Easy Tutor. Welcome back to my channel, and thank you for returning. In part 3 of this antibiotic lecture series, the focus of the presentation will be on anaerobic and atypical bacteria. I hope you are able to study the first 2 parts of this lecture series. A surprise quiz might pop up at any time. Thank you again for tuning into my site to watch my videos. And now, part 3. This is part 3 of 4 of the Antibiotics Made Simple lecture series. In this part, we're going to talk about anaerobes and atypicals, the middle section of the antibiotic grid. But before we start talking about anaerobes, surprise, it's pop quiz time! I'll be asking a dozen questions on the material that we've covered so far. It'll be a good gauge to see how well you retain the information. After the question, I'll leave a gap of time so you can think of the answer. Place the video on hold if you need more time. Okay, here we go. Question number 1. If you have a positive blood culture for MSSA and it is sensitive to cefazolin, oxacillin, and vancomycin, which is the best antibiotic you would use to treat the infection? The answer is oxacillin, because semisynthetic penicillins are superior clinically over vancomycin or cephalosporins. So I hope you got that answer right. We'll move on to the next question. Question 2. When vancomycin treatment has been ineffective in treating the following MRSA infections, which antibiotic would you recommend to use next? For MRSA cellulitis, MRSA pneumonia, and MRSA sepsis. So you have an MRSA infection treated with vanco, but it hasn't been effective. Which antibiotic would you turn to next? The answer is for MRSA cellulitis, tigecycline, MRSA pneumonia, linezolid, and MRSA sepsis, daptomycin. Question 3. Community-acquired MRSA can be treated with which 3 oral antibiotics? The answer is doxycycline, trimethoprim sulfamethoxazole, or clindamycin. Next question, number 4. The drug of choice for coagulase-negative staph infections is the answer is vancomycin. Question number 5. True or false? The microbiology report that you received shows 1 out of 2 blood cultures are growing coag-negative staph. This means that you need to immediately treat the infection with antibiotics. The answer is no. You don't need to immediately treat the infection because it might be a contaminant. But what you need to do is look at the patient and see what the severity of the infection is and ask, are antibiotics appropriate for that clinical situation? Question number 6. The most common cause of community-acquired pneumonia, or CAP, is the bacteria named The answer is Strep pneumoniae. Question number 7. Strep throat is caused by which Streptococcus species? Strep throat is caused by Strep pyogenes or group A strep. Question number 8. Name 3 antibiotics that can be used to treat strep throat. We can use Pen-VK, amoxicillin, cefdinir, cefpodoxime, or clindamycin. Question 9. The 2 IV antibiotics that are recommended to treat flesh-eating bacteria that's solely caused by Strep pyogenes are the answer is penicillin GK and clindamycin combination. Question number 10. Uncomplicated intra-abdominal infections caused by Anaerococcus faecalis is treated with which antibiotic if the patient has no allergies or if the patient is penicillin allergic? The answer is if the patient has no allergies, ampicillin. If they're penallergic, it's vancomycin. Remember that Anaerococcus faecalis is in that special group, which is a VIP group that has limited number of antibiotics that can be used to treat it. Question 11. Urinary tract infections caused by Enterococcus faecalis or Faecium is best treated with which oral antibiotic? We can use nitrofurantoin to treat these types of urinary tract infections for both enterococcal species. And now the final question, question number 12. Question number 12. Which 2 antibiotics can be used to treat moderate to severe VRE infections? VRE is vancomycin-resistant Anaerococcus. The answer is either linezolid or quinupristin dalfopristin. Well, how well did you do? Hopefully you did a great job. Please take a minute to relax before continuing on with the lecture. Okay, so now we're going to move along and talk about anaerobes, and later on we'll talk about atypicals. Now you can see how anaerobes can play a major role in causing intra-abdominal infections. So here's our familiar table of the bacterial spectrum. And as I mentioned earlier, the anaerobes and atypicals formulate the middle section of this table. Now don't forget that anaerobes are also linked with gram-positive cocci and gram-negative bacilli, forming the 3 major groups. So it's important to remember this type of relationship. What are the characteristics of anaerobic bacteria? Anaerobes are part of the normal flora of the skin and mucous membranes. They're found in the oral cavity, in the bowel, and female genital tract. What are some important clues of having an anaerobic infection? Well, quite often, an important clue of an anaerobic infection is that it's foul-smelling. There's foul-smelling discharge and putrid drainage. This can be caused by tissue necrosis, gangrene, gas in pus, or infected tissues. Now, oftentimes the site of infection is adjacent to mucosal surfaces. And after animal or human bites, it may be suspected that this could be an anaerobic infection. Gram stain usually shows polymicrobial flora, which means that anaerobes are often combined with gram-positive and or gram-negative bacteria. A third aspect of anaerobic bacteria is that isolation of anaerobes is often very difficult. It requires specific measures and precautions for properly collecting and transporting the anaerobic specimen. Furthermore, anaerobes are difficult to grow. They require special methods for cultivation, and they're slow growing. So therefore, anaerobes are not routinely cultured, and most infections are treated empirically. Now, an important concept to remember when we're talking about anaerobic bacteria is that it can be classified into two groups based on the anatomical location relative to the body's diaphragm. Above the diaphragm anaerobes are anaerobes that are found in the mouth and upper GI tract. And there's a whole host of bacterial species that are found in this group. Below the diaphragm anaerobes occur in the colon and small intestine. And the major anaerobe in this group is Bacteroides fragilis, or commonly known as B. frag. First, we'll talk about the anaerobes that are located above the diaphragm. Now, as I mentioned earlier, there are a considerable number of species within this category. We don't need to memorize all the names of these species, but we'll consider these as one group, calling them above the diaphragm anaerobes. Now, what type of infections do these above the diaphragm anaerobes cause? They can cause dental infections such as tooth abscess, gingivitis, and periodontitis, and it can cause three different types of abscesses: peritonsillar abscess, brain and lung abscesses, and it can cause aspiration pneumonia. Now, how do we treat these above the diaphragm anaerobes? Well, before, penicillin was very effective against these anaerobes. But with time, now resistance developed against penicillin, and we now need to add beta-lactamase inhibitors to the penicillin. And by doing so, we get about 90% effectiveness. If the patient has an allergy to penicillin, we can consider using clindamycin. But it's always best to check the local resistance patterns for each of these species and type of infection in your area. Specific antibiotics that can be used are for oral antibiotic or oral administration, amoxicillin clavulanate or augmentin, and clindamycin can be given orally. IV therapy can be ampicillin sulbactam or Unicin, piperacillin tazobactam or Zosyn, metronidazole or clindamycin. When we talk about anaerobes that are located below the diaphragm or gut anaerobes, Bacteroides fragilis or B. frag is the predominant bacteria that we're going to be talking about. Now, there are some species of Bacteroides that are in the gut, but they're minor compared to the number of Bacteroides fragilis or B. frag that's located in the gut. Now, what types of infections can be involved with these types of anaerobes? Intra-abdominal infections can be caused by B. frag. And this can not only be anaerobe or purely anaerobic, but it's also found to be mixed with other aerobes, either gram-positives or gram-negatives. Abdominal abscesses and liver abscesses can occur with these types of below the diaphragm anaerobes, and also other types of anaerobic infections like pelvic inflammatory disease, diabetic foot infection, or bite infections, either animal or human, can occur, and anaerobes can be involved with those types of infections. Bacteroides fragilis or B. frag is the most common cause of these intra-abdominal infections, and they're primarily found in these abscesses. And these are mostly mixed infections, as we've mentioned earlier. They usually have other types of aerobic bacteria that are also mixed in with B. frag. It resides in the colon and female genital flora, And it can also cause aspiration pneumonia and other types of infections such as sepsis, lung and brain abscess, diabetic foot ulcers, and necrotizing fasciitis. Now, how do we treat below the diaphragm anaerobes? Well, over the years, increased resistance to Bacteroides fragilis has occurred, and this is making treatment of anaerobic infections below the diaphragm very difficult. Metronidazole does remain highly effective for intra-abdominal infections caused by B. frag. But we used to rely on antibiotics like clindamycin, moxifloxacin, and ampicillin, sulbactam, or unicin. But these can no longer be used for empiric treatment of serious infections because resistance has occurred. Now, we also need to check local resistance patterns in each of your areas to determine what type of empiric antibiotic treatment you can use for intra-abdominal infections. As far as which antibiotic to use, we will refer to the chart on the next slide. Let's talk about the specific antibiotic treatment of B. frag intra-abdominal infections. Metronidazole is the premier antibiotic that we want to use against B. frag. As you can see, it has a 4-star rating against anaerobes in the belly. Metronidazole is considered a pure anaerobic antibiotic. It has no gram-positive and no gram-negative coverage. This allows metronidazole to have a very specific and selective attack against anaerobes. It is considered the drug of choice for intra-abdominal infections caused by B. frag. Metronidazole has a low resistance rate, but it is increasing. When taken orally, some patients experience a metallic taste. Patients should be consulted not to take alcohol while taking metronidazole due to the potential of a disulfiram reaction, which is described as symptoms of nausea and vomiting, dyspnea, tachycardia, and flushing. All of the second-tier antibiotics have good to excellent B. frag anaerobic coverage. In addition to hitting B. frag, they all have extended broad-spectrum coverage that might be unneeded for certain types of intra-abdominal infections. This unneeded overexposure by the antibiotic can lead to resistance to gram-positive and gram-negative bacteria. This can be termed collateral damage against aerobes. For example, piperacillin tazobactam and meropenem imipenem are widely used antibiotics. These antibiotics are effective against Pseudomonas aeruginosa. However, inappropriate overuse of these agents, where Pseudomonas aeruginosa is not an organism that is causative, can lead to increasing resistance of Pseudomonas aeruginosa. For the other carbapenem, ertapenem, overuse can lead to diminished effectiveness against a multidrug-resistant organism named ESBL, which is primarily treated with carbapenems. Penicillins and cephalosporins are not effective against ESBL. So you can see that we need to reserve ertapenem for ESBL and not use the antibiotic inappropriately or for unnecessarily long durations. Tigecycline, the same holds true for this antibiotic, as overuse can result in MRSA becoming more difficult to treat. Eravacycline, a new tetracycline, has some promise as a key intra-abdominal antibiotic, since it is not as broad spectrum as the other antibiotics. As far as the old standbys, there are 4 tried and true antibiotics that have been used to treat anaerobic infections for many years. They have good anaerobic coverage and are not as broad spectrum as the second-tier antibiotics listed above. However, unfortunately, overexposure to these antibiotics have led to a growing rate of resistance to B. frag, to the point where, due to increasing resistance, none of them can be trusted to be used empirically against serious intra-abdominal infections. Many of them have been relegated to use only for surgical prophylaxis. Clindamycin has some gram-positive activity, but it has no gram-negative activity. So in the past, it was an ideal candidate for targeting intra-abdominal use. However, due to many years of use, it has seen declining anaerobic coverage. For moxifloxacin and ampicillin sulbactam, not only have we seen an increased resistance to B. frag, but they have also developed resistance to E. coli. We talked about anaerobes that are located above the diaphragm and below the diaphragm. And now we're going to talk about a third category of anaerobes named Clostridia. Clostridia are spore-forming anaerobes that are responsible for some very serious human infections. They account for about 10% of all anaerobic infections. Now, significant members of this family include Clostridioides, formerly Clostridium difficile, which causes C. diff, severe diarrhea, and colitis. Clostridium perfringens, which causes food poisoning and a tissue infection called gas gangrene. Clostridium botulinum, which causes botulism, food poisoning with neuromuscular symptoms, and Clostridium tetani, which causes tetanus, a neurologic disorder with muscle spasms and CNS toxicity. Now, the scope of this discussion on Clostridia is too large to be included in this lecture series, and so we'll be covering Clostridia in a future separate lecture which will focus in on the treatment of Clostridioides difficile. Now let's move along and talk about the atypicals. Atypical bacteria comprise 3 bacterial species: Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella pneumophilia. Atypicals are often forgotten, and they're thought of as the lonely bacteria. Now, atypical are called not typical because they are not detectable on gram stain. They remain colorless since they lack a peptidoglycan cell wall that normally holds the stain. They're smaller than other bacteria, and they're neither gram-positive or gram-negative, and that's why they're often forgotten and termed the lonely bacteria. However, atypicals are very important because they can cause respiratory illness and pneumonia, so one can't forget about them. Atypicals are an important cause of respiratory illness and pneumonia. It's very common to find it along with strep pneumoniae, H. influenza, and viruses like the influenza virus. Atypicals don't cause the same typical clinical picture as lobar pneumonia. They tend to have milder symptoms and different symptoms than typical pneumonia, and they appear different on chest X-ray. And atypicals are hard to detect using standard methods. Cultures take 1 to 2 weeks to complete, and so diagnosis has previously been performed using serology in virology labs. However, now we can use nucleic acid amplification techniques using what's known as PCR or polymerase chain reaction or rapid diagnostics on these respiratory specimens for faster identification. Let's go over each of the 3 atypical bacteria individually. The first one, which is the most important, is Mycoplasma pneumoniae. It's the second leading cause of community-acquired pneumonia, or CAP, behind strep pneumoniae. It's responsible for the vast majority of atypical respiratory infections. Now, most cases of Mycoplasma pneumoniae infection are mild, and they will resolve on their own. This is so-called walking pneumonia. However, about 10% of patients who acquire Mycoplasma will develop severe pneumonia. Mycoplasma pneumoniae is the smallest free-living organism. Now, we treat Mycoplasma pneumoniae with doxycycline. Alternatively, we can use azithromycin. It also has the highest attack rates among 5 to 20-year-olds, and it's one of the major causes of pneumonia in young adults. It also occurs with advancing age, especially the elderly. The second atypical is named Chlamydia pneumoniae, and it causes a clinical picture that's very similar to mycoplasma. It's an acute febrile illness that becomes either self-limiting or develops into a mild pneumonia or bronchitis. We generally treat that also with doxycycline and alternatively azithromycin. The third atypical bacteria is named Legionella pneumophila, and it's the most pathogenic of all the atypical bacteria that causes lung infections. If you don't treat Legionella quickly, it can lead to a very severe course, and the illness can become quickly severe. Now, the name Legionella was derived from the first outbreak of this organism at an American Legion convention held in Philadelphia in 1976. Legionella is known as an aquatic bacteria. It likes places where water stagnates to allow it to proliferate. Most of the cases are due to inhalation of the pathogen that's linked to water systems, especially air conditioning and water faucets, respiratory therapy equipment. The preferred treatment are quinolones, such as levofloxacin or moxifloxacin. And alternatively, we can use azithromycin or doxycycline. It is seen most often in middle-aged and older adults and patients who have chronic illnesses or weak immune system. Now, aerosolization and inhalation of Legionella pneumophila can lead to outbreaks of a self-limited febrile illness called Pontiac fever, or it can lead to a more severe systemic illness with pneumonia, which is called Legionnaire's disease. So let's review this section on anaerobes and atypicals. Here are some important take-home points to remember. Some key characteristics of anaerobes are that they may cause foul-smelling infections, they are not routinely cultured when suspected, since their collection requires specific techniques, and they are usually not found alone, but are typically found coexisting with aerobic bacteria to cause mixed infections. Above the diaphragm or mouth anaerobes used to be sensitive to penicillin, but it now requires antibiotics that have a beta-lactamase inhibitor. Below the diaphragm anaerobes are predominantly Bacteroides fragilis or B. frag, which primarily causes intra-abdominal infections. So how do we treat B. frag? Metronidazole is the drug of choice for intra-abdominal infections caused by B. frag. Metronidazole is a pure anaerobic antibiotic. It has no gram-positive and no gram-negative activity, so it specifically targets anaerobes. When we talk about second-tier choices, all of them have good to excellent B. frag anaerobic coverage. In addition to hitting B. frag, they all have broad-spectrum coverage that might be unnecessary. The expanded bacterial spectrum these antibiotics cover may not be part of the causative agents of the current infection. This unneeded overexposure by the antibiotic can lead to resistance. Piperacillin, tazobactam, and meropenem imipenem are widely and maybe overly used antibiotics. Inappropriate use can lead to an increase in resistance of Pseudomonas aeruginosa. Ertapenem, a carbapenem, overuse can lead to diminishing effectiveness against ESBL, which is a multi-drug resistant organism that's primarily treated with carbapenems. And the same holds true with tigecycline, where overuse can lead to MRSA becoming more difficult to treat. Eravacycline, a new tetracycline, has some potential since it's not as broad spectrum in coverage. There are some tried and true antibiotics that have been used for many years to treat anaerobic infections, but unfortunately, overexposure to these antibiotics have led to a high rate of resistance to B. frag, to the point where none of them can be trusted to be used empirically against intra-abdominal infections. Many of them have been relegated to use only for surgical prophylaxis status. Clindamycin has declining anaerobic coverage. It has some gram-positive activity, but no gram-negative coverage, so it previously made a very good targeted anaerobic antibiotic. Unfortunately, though, resistance has caused its use to be not as effective as before. Moxifloxacin and ampicillin sulbactam not only has declining anaerobic coverage, but also is developing resistance to E. coli. The atypicals consists of 3 key bacteria. Mycoplasma pneumoniae causes the majority of all atypical infections. It mostly causes a mild self-limiting respiratory infection that resolves on its own, and it's common in young adults. Chlamydia pneumoniae also causes respiratory infections. It's very similar to Mycoplasma. The treatment of both is doxycycline. Azithromycin can be used alternatively. Legionella pneumophilia is an aquatic bacteria that's found in air conditioners, ventilators, water faucets, etc. It infects mostly older adults and the elderly. For Legionella, quinolones are preferred as the treatment of choice, but azithromycin can also be used. A self-limiting febrile illness caused by Legionella is named Pontiac fever. When you get a severe pneumonia caused by Legionella, this is called Legionnaire's disease. Congratulations! You successfully completed part 3 of 4 parts. You're almost done completing your antibiotic competency. And look what your learning has continued to do to Mr. Bacterium. Thanks for tuning in to watch this episode of the Farm Easy Tutor. I hope you learned something that you could use in practice or at school. There was a lot of material presented, and it does take time to study all the information. If you would like to continue to see more of these types of tutorials on YouTube and to stay informed when the latest material is available to view, please make sure to click on the subscribe button below. You can now see that success is just around the bend and that we're almost done. Today we completed reviewing anaerobes and atypical bacteria. Please join me next time in the final part of this lecture series. In part 4, I'll be talking about how we treat gram-negative infections. Stay tuned to the Farm Easy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.